donor have all acknowledged that it was an over-ambitious target that we did set at the beginning, and this is under review. Part of this workshop will be to talk about these targets as well as some of the outcome targets that we had set. So that will be part of our discussion. But I've kept it up there as this is the existing target for 2015. 3 main outcomes: children and their mothers are well nourished, protected from infection and disease, and have access to essential health services. We have our direct beneficiaries that we had targeted at the design phase of this program. That number has changed as we have started to implement the program. The number has increased. And also, remember, we also have the indirect beneficiaries of this program. I'm sure most World Vision staff are familiar with this particular slide. It talks about the problem, the global problem in terms of the very high maternal and child mortality. We know what the issues are, what the challenges are, what is responsible for this very high death or what contributes to it. We know the regions in the world where we have the highest rates. But also, interestingly, we know what the solutions are, what the interventions are that have been proven to work globally in very difficult, challenging conditions. Nonetheless, there are simple cost-effective interventions that make a difference in addressing these problems. So what is this program going to do about it? What is the mHealth program doing about it already? You're all familiar with the 7-11 core interventions, which have been drawn from globally acceptable interventions approved by the World Health Organization, by UNICEF, and American Colleges of Nursing and Midwifery. We know these things work. We know these interventions have worked in different situations. And these are the core interventions referred to as the 7-11 core interventions for this program. In terms of within the child development cycle, from the point of pregnancy of the mother right through to delivery and school age of the child, as they grow during that period, there are different things that happen and therefore different interventions. However, this program is focusing just within this area of the child development cycle. That's where this program is focusing on in terms of its interventions. We are also familiar with the time and targeted counseling approach, which is our core model of intervention, one of the core models of intervention for this program, timed to make sure that we are giving the messages at the right time that it will have the benefit to the mother or to the family, so that it's not too soon, not too early or not too late. If it's too late, the benefit is lost. If it's too soon, they might forget and may not practice the intervention. During these periods, there are several stages of visits, household visits, by the community health workers. I'm not going to dwell on some of these slides because you're all familiar with them. We also have the 360-degree of behavior change. Behavior change communication is a core approach for delivering the messages at the household, the 7-11 messages. And we are intervening through this program at the individual level, and in doing that, we consider also the other decision makers or influencers of changing behavior within the household. And we intervene to ensure that the communities around the individual that influence that decision making are also brought into the discussions. We also intervene at the environmental level, where we talk about government policy, the health systems around them, the socio-cultural practices within communities. As you present your findings during the course of the next couple of days, I'm sure you're going to be referring to this, how contextual conditions or contextual issues, societal, cultural practices have impacted on our ability to achieve some of the degree of change that we had hoped for. So what are we doing? At the individual level, we are using TTC to intervene. At the community level, we are using the community comms model, which is the community committee model, strengthening community health systems to intervene at the community level. And at the environmental level, we are using our advocacy model, the citizen voice and action, to intervene at that level. So we are using these three core models as our core models of intervention, but we also have PD Health, which is a nutrition model that we use within the program implementation. Of course, by taking that kind of approach, we are hoping to have a holistic kind of impact on the lives of women and children. So World Vision International's health and nutrition strategy talks about the 7-11 interventions, which I just mentioned briefly, the TTC, time and targeted counseling, the citizen voice and action, and PD Health as our nutrition model. And we are using what is referred to within World Vision as interventions bundling, which simply means that you are bringing together a range of interventions to have impact on the community or on the beneficiaries, so that you're not using one intervention all the time and then maybe after that you come back and try another intervention, and if that doesn't work, or you try another intervention. Instead, we are using them simultaneously in an interventions bundling approach to impact on our beneficiaries. I've already mentioned the comms model. We are building the capacity of the community committees as part of our community system strengthening, and also trying to do a kind of developmental work that engages the community and helps to sustain the program going forward, or the achievement of the change that we want to achieve. Of course, you've heard this morning that we are partnering with the Ministry of Health. They are the implementing partners. World Vision is not implementing this program. It is the Ministry of Health that is implementing it. We are providing the resources through the funding that we receive from the donor. We're providing the capacity building because we have the technical capacity in terms of these various models. We already heard about the importance of evidence base, being able to produce the evidence to support the work that we are doing, but also to draw the lessons learned from our experience of implementing this program and sharing that, and taking note of the best practices or emerging best practices from our program implementation. So we have a local academic partner in Ireland that is working with us in terms of our operations research. We also have local academic partnerships. We've also recently, this program has joined the Global Fellows Program, which is run by our global office, World Vision International Global Office, and Erin Jones is here, who is the coordinator for that program. And through that, we've been able to source global fellows that have supported our midterm review process. They've done the qualitative, in-depth interviews, and they took the focus group discussions that were done as well, and the findings from that, combined those to produce a qualitative report for this midterm review. They also did the list analysis, part of which you will hear about sometime during the course of today or tomorrow. One of the global fellows is here, Kevin, who has been attached to the Uganda team. Sustainability is something that we talk about quite a lot, but for this program in particular, we also focus on it. We don't just talk about it. From the design phase of this program, because sustainability is something you don't do as you are exiting the program. You start to work on it from the design phase, and throughout implementation, you ensure that you are building the capacity of the communities, the capacity of the Ministry of Health, the local communities, to ensure that the changes that you are introducing are sustained. So what do we do with this program? Primarily, this program focuses at the community level. So we do community system strengthening with community health workers, village health teams, as you call them here. We established the community committees. Some of them were already in existence before this program was introduced. So what we've done is to rebuild those committees, because in some countries they had become non-functional. In the case of Mauritania, these committees did not exist. They did not have community committees. But actually, within the program areas, 40 new community committees have been established, and they are functioning effectively. I've already mentioned CVA. We also do organizational and technical capacity building for the Ministry of Health counterparts that we work with. We do some amount of health system strengthening, but this is an area where we need to develop a little bit more. We provide capacity building, some training in terms of our core models and the BMOC and CMOC training that has taken place in some of the countries. But this is an area that we need to continue to improve on. We do some work with the Ministry of Health, in fact, a lot of work in strengthening the data management systems. We've introduced mHealth in the ADPs in Sierra Leone and the 3 ADPs here in Uganda. And we are hoping that in our next phase, we will have mHealth as a common core component for all the community health workers that we work with. So it's not a separate project. It's an integrated tool for the community health workers. Some photographs of our field work. I just want to refer to this photograph here of one of the DMOs in Uganda, in Tanzania. And he's holding up this document. That's the Ministry of Health's detailed implementation plan for the Ministry of Health. And what he was saying to me during our visit is that all the activities, all the targets, and all the outcomes that are expected to come out of this program for mHealth are in that document. That's the Ministry of Health's document. That's the DMO, and that's the document that his superiors and supervisors at the national office will be using to assess the performance of the district, the Ministry of Health district. That's how well integrated our program has become across. In fact, this is just an example of one country, but this is what we now have across the 5 countries. That's the level of integration that we have with the Ministry of Health. Here, you see one of the community health workers here using a flip chart, or what you call it now. Pardon? Counseling cards, that's right, that's the word I was looking for. With the pictures on one side showing or illustrating a particular point that she's trying to make, but on the other side of that card, she's got the details written down as to what sort of advice or message she is giving to community members. And you can see some of the family members sitting around as well. That was a training session, but that just illustrates how the counseling is done. Up here, this was in Kenya. During one of our monitoring visits, we went to one of the health facilities. You can see how many mothers and children turn up there for ANC and PNC visits. At the bottom here, we have this child whose mother died during the course of delivery, when that child was being delivered. And the grandmother took over the responsibility of looking after that child. But that child, in fact, was malnourished. But through our PDHAT program, that child made remarkable improvement in weight gain. So again, our PDHAT program been quite instrumental there. Here we have, during the last Irish Aid visit, the monetary visit in Busia, we have Susan, who is here, and Columba, who is the portfolio manager for this grant with Irish Aid. So she's the person that I link with on a regular basis in terms of this program, our link person for World Vision Ireland. And the community health worker, this lady was actually a TBA, a traditional birth attendant, but was recruited onto the program. She joined the program and trained as a community health worker. And so she's no longer working as a TBA, but working as a community health worker and supporting women to deliver in health facilities. She's also carrying a mobile phone. That's the extent to which we've impacted on the way she practices. Not only practicing as no longer practicing as a TBA, but practicing now as a community health worker, and with a mobile phone to collect data and submit that data to the Ministry of Health. We also have here a meeting with one of the DMOs who happens to be here, during the monitoring visit. Again, a PD health session that was visited by the Irish Aid team. And here we have one of the community ambulances that was purchased for the Uganda, one of the districts here in Uganda. I think that was Lunio. And we have this provided for nearly all the districts that we are working in. Some districts have a bit of challenge, and they're looking at other options. Finally, I just want to kind of not go through the details of this, but just to highlight some of the key comments and findings or recommendations from Irish Aid during the course of their monitoring visit. You can just read for yourself the very first statement, which interestingly, Susan herself during the course of her remarks here actually pointed out to the fact that overall the conclusion of the monitoring visit from Irish Aid was that the AIM Health program is strong, focused, and that it is making an important contribution to child and maternal health in the targeted communities. For us, I think coming from the donor who has gone and visited the program is very encouraging for us. But we should not take that as, well, job done. This is just the beginning. We have a lot more to do, but it's encouraging to hear that. A number of other recommendations in terms of the strength of the program, our consultative, participative approach with the ministry, with the local communities and engaging with them. The need for us to strengthen the resource-based management and in particular our monitoring systems. Also the comment about ensuring that explanatory notes are provided in regular program reports that we are making.
Please.
Am I away from the microphone? Okay. And then finally, the comment as well about the partnership between this program and the Center for Global Health. The issue of ensuring that the evidence base is being produced and that it's informing program implementation going forward, because that's what operations research should do. It should be able to look at how the program is being implemented, what is working well, what's not working well, where is the evidence to show that our models are working well, and feeding that information back to the program to improve program implementation, but also sharing our findings with other colleagues and other programs. Beyond 2015, we are beginning to think about what happens when this program comes, when this current funding comes to an end. Already, we have this midterm review. The evaluation that we are committed to with the donor should happen in the last quarter of 2015 with an external consultant who has not been involved, or a consultancy that has not been involved with the design and implementation of this program, being given the responsibility to make that evaluation, with reporting back to the donor in the first quarter of 2016. So this evaluation should take place in the last quarter of 2015 and the reporting in 2016. We also now have formal notification from Irish Aid that we are getting other NGOs as well benefiting from the current round of funding. We have a one-year extension for 2016. So although the current funding is coming to an end in 2015 and the evaluation will be done then, we have 2016 as an extension for continuing to implement the program. During that period as well, we will be looking at, when the call comes from Irish Aid for the next round of funding, another 4 years of funding, we'll be looking at phase 2 from 2017 to 2019, or is it 2020? And we hope that we'll be able to put together a proposal that is robust and strong enough to attract enough funding for the various options that we would like to consider. Option 1 is in terms of maintaining the current ADPs, but deepening our current interventions, our models of interventions. But certainly adopting an integrated systems approach, as we already have been referring to the increase in demand that we've generated in the community for use of health facilities. What happens when they get there? The health facilities are not adequately equipped, human resource-wise or equipment-wise, to respond to that need that we've generated. Very quickly, what is going to happen? The women will start to ask, well, why are we bothering to go to the health facilities if if they cannot provide the services for us. So if this program is to be strengthened going forward, that is something that we need to address as a priority for phase 2. There is also another option coming up, which is doing this option 1, plus looking at a district-wide scale-up, as you've already heard from the Ministry of Health in Uganda here. This is the same comment that we are hearing from the other ministries of health as well across the other countries, about scaling up to the whole district as opposed to just World Vision ADP areas or World Vision Island ADPs. So that's something also that's under consideration. No decision has been made, but it's an option that's on the table under consideration and we'll be discussing. Option 3, maybe by the end of this workshop, you will help us to think about what other options may be there, or are we just going to focus on these 2 options? That's the end of that presentation. I hope I haven't gone too fast or too quickly, but I'm sure you are familiar with most of the things that I've said, if not all of them. So there was no need for me to do, is this on the training session? Okay, all right. Okay, any immediate questions? Any questions about that presentation? Sorry. Okay. Yes?
Thank you very much for the presentation. I just have maybe one question or 2 comments. One, we're very grateful about the community health system strengthening.
Yeah.
One, I want to appreciate the presentation. Thank you very much. 2, I wanted to inquire about 2 things. One about the implementation of the BMOC and EMOC. I don't know in the other countries it's being done actually. I think in our countries we're actually saying should be included. And then I really appreciate the issue about scaling up to the district level. Number 2, I wanted to talk about the models. I think from 2012 up to now, we've been in discussion with World Vision that in terms of the TTC model and the COMS model, in Kenya we have the maternal, neonatal, and child health model, which actually we agreed has a team that it includes all the